FOB, the flexometallic or did you mention it, sir?
flexometallic. Yeah, but the
Exometallic we have to.
flexometallic is
Or
ideal.
nasal ray. A nasal ray.
Nasal ray may be little difficult
Surgery
to
is
do a
Yeah.
fiber optic, because of the bend and all those things. Okay.
Intraoperative maintenance of the tubes, because it will get kinked, sir, all the time.
Yeah. So that is another thing. So is the slide visible there? So analysis
Yes,
of the
yes,
case, it is a known or anticipated difficult airway due to limited mouth opening. This is the most important challenge in this case. Then history taking, what is the possible etiology, whether it is congenital or acquired. So in congenital only, majority of the time you get OSA. Acquired, you don't get it that often. Then how did the patient manage to maintain nutrition? That is another important history taking. Oral hygiene and any dental issues before the plan surgery, and whether there is any OSA due to micro or retrognanthia. So these questions should be taken in the history. Then you must know all about difficult airway. First of all, definition, then causes of difficult airway, assessment of difficult airway, plan for management. Normally they talk about plan A, plan B, plan C, and plan D. And nowadays they can ask you about the difficult airway algorithm. So many societies for difficult airway are there in all the countries. Even our own Indian Society of Anesthesia and has come out with an algorithm as close as 2022. And so some examiner, if he happens to be one of the member of that committee which formed the algorithm, definitely they may ask you this. So be prepared to memorize and try to remember all these steps or the flow chart in the difficult airway algorithm. And they may ask you about difficult airway cart. What are all the gadgets that you should have with the difficult airway cart? And you must know something about how the gadgets are used, like the fiber optic or the trans-elimination wand is there. So other gadgets which are used in this particular condition, they may be asking you about that. Then the discussion of how to secure the airway. First option is awake fiber optic nasal intubation. Second will be blind nasal if you are good at it, or if you have no fiber optic. And third will be the tracheostomy. These are the only three options you should say. No one mention anything else because there is no mouth opening. So no video laryngoscope, no supraglottic airway. Sometimes they may ask you about retrograde intubation. I specifically did not mention that because even though textbook wise retrograde intubation may be a choice, but practically it is not that easy to do a retrograde in a patient without a proper mouth opening to pick up that guide wire from the nose and all that. It is not very easy to make it practical. So I have not mentioned, but please remember retrograde also. Some examiner may expect that answer also. So the fourth option is retrograde intubation, where you can put a 2He needle in the cricothyroid membrane and use the same guide wire and bring it through the nostril and railroad your tube. Of course, that is very cumbersome. And the surgical techniques are, you can have gap arthroplasty, you can have, nowadays they replace the temporomandibular joint itself with the titanium prosthesis. So that much of advancement has come. And the success of the surgery is getting adequate mouth opening. At least 3 finger breadths mouth opening should happen. So at the end of the surgery, if the patient is on tracheostomy, you can safely continue with the tracheostomy to allow the patient to breathe spontaneously, reverse, and then decannulate him after 24 to 48 hours. On the contrary, if you have made a nice nasal intubation, either by a fiber optic or by blind nasal technique, then always try to see whether you can pass your conventional laryngoscope after the mouth opening is achieved and visualize to the epiglottis, and be sure that you can re-intubate the patient. If that is satisfactory, that you can re-intubate at any time, then you can wake up the patient, reverse the neuromuscular blockade, and extubate the patient. If you have any doubt, but still you want to avoid leaving the tube, because leaving a tube in situ, nasal tube in situ, it is prone with the complication of tube blockage because of the secretions and the incrustation. So if you are worried about this, always leave a tube exchanger through the nostril into the trachea and then extubate the nasal tube. So these are the answers that are expected out of you. So this is for my reference, where I have talked about this. I'll just show you the picture. So for the benefit of those, this will be the picture of a patient with severe Christmas or the TM joint ankylosis. Absolutely no space at all. So this is called complete ankylosis. Absolutely no gap at all. And this is the way the micronanthia patient will be there. So they will have OSA problem because of the micronanthia. So they have bird-like faces, and so this is how the surgery is done. They can remove type 1, type 2 like this. So this is where they have to remove that configuration. So this is how the CT scan will look like, and this is the initial opening, partial ankylosis, and patient have been, and at the end you should achieve an opening like this. So from this level, if you are able to achieve at this level, that means that that's a good release. Okay, so once you achieve this level, you can easily put your scope and intubate at any time. So that is how the whole surgery is done. Okay, so just for the visual impact of that, it will be the method of joining. Okay.